Welcome, everybody. On behalf of the President, Dr. Nasser Al-Juhani, and on behalf of the Board of Directors, I'd like to extend a very warm welcome to all of you for joining us at this webinar. We are thrilled to have you to join us for this insightful discussion. Today, we're honored to have Dr. Ahmed Al-Qaisi, a renowned expert in the field of thyroidology, as our guest speaker. He brings a wealth of knowledge and experience in this field, and we are excited to hear from him some insights about the thyroidology. Dr. Ahmed Al-Qaisi, after graduating from the famous University of Baghdad, he did all his medical training and specialties and research degrees and work experience as a consultant in the UK for more than 20 years. He was leading the thyroid services in the famous Leeds teaching hospitals, and he was involved in many published research papers and respectable journals. Now, we're lucky to have him. He's a consultant endocrinologist at the Imperial College London Diabetes Center in Abu Dhabi. And I'd like to ask you to give him a very warm virtual welcome to Dr. Ahmed. Dr. Ahmed, the stage is yours.
Thank you very much, Dr. May. I'm quite honored by this invitation. Thank you very much, everybody, for coming in such late time in Middle East. The good news, I didn't make a very lengthy presentation, only 15 slides, so we'll make it quite interactive. I just went through the most recent evidences that we have on some guidelines. So our talk today is about the TSH receptor antibody and how it is relevant in the diagnosis and management of a grave disease. So my aim is to talk about the TSH receptor component that will bind to the TSH receptor antibody, and we'll talk about what assays are available now of TSH receptor antibody, and how these assays can make difference in the management, especially the old assays compared to the new versions of the assays. We'll also talk about the relevance of TSH receptor antibody in the diagnosis of grave disease and comparing this to the gold standard diagnosis of grave disease with radio uptake scan. And also we will mention some figures regarding what levels of TSH receptor antibody we could see during the course of a grave disease and whether there is any benefit in measuring TSH receptor antibody at the end of treatment with antithyroid medication, and whether we should decide about the more definite management from the beginning with the grave disease, depending on the level of TSH receptor antibody. And we'll see if there is any relevance with the pregnancy and also with the graves ophthalmopathy. And also I found some study regarding TSH receptor antibody in normal population, and then we will conclude at the end. So the TSH receptor is such a unique receptor. It is made originally of more than 700 amino acids. It will go into cleavage and it will form two main subunits, the alpha subunit and the beta subunit. And you could see that from the plasma membrane side there, the alpha subunit is just outside, and the beta subunit will organize the activity that will be provoked by TSH binding to the alpha subunit. Now, when TSH bind or the TSH receptor antibody bind, it will start this cascade of changes that will end up in having increase in cyclic AMP inside the cells. Now, because this is outside the plasma membrane, this alpha subunit sometimes can be shed outside, to the bloodstream. And once it is shed outside, it will lead to sometime immune response in certain individuals, leading to creation of TSH receptor antibody. So this is how TSH receptor antibody is made. And we are quite lucky in diagnosing grave disease. We could use TSH receptor antibody and compared to other autoimmune conditions. Other autoimmune conditions may require much more antibodies compared to a grave disease, while in a grave disease, we have a unique TSH receptor antibody. Now, what assays we have? Now, the major assays that is used around the world is TBII, which is thyroid binding inhibition immunoglobulin. Now, this assay uses all types of TSH receptor antibody measurement. And what I mean by that is we all know that TSH receptor antibody is either stimulatory or inhibitory or neutral. And this assay works by having a TSH receptor, having a TSH radio labeled that will bind to the TSH receptor and compete with the antibody on the site. And hence, we wouldn't know whether that antibody is a stimulatory or inhibitory. Now, the assay was first described in 1960, and the first assay that was commercially used was in 1974. And the first assay was in a liquid form, and they called it as first generation. However, it had a fairly low specificity and sensitivity. From 1990, we started to have the second generation assay. They call it the solid form. And then in 2002, the third generation came. And the second and third generation are quite sensitive and specific to the Graves' disease. And they could reach up to more than up to the 90% cutoff when we use 1.75 IU per liter of TBII to diagnose Graves' disease. The other assay that is available is called thyroid stimulating immunoglobulin. And from its name, we detect the stimulating antibody with this assay. And how do we measure this assay? This assay works by, we will let the antibody bind to the TSH receptor site. And then we will measure the cyclic AMP. Hence, we will know if that antibody is stimulatory, it will lead to an increase in cyclic AMP. And this would be more specific antibodies. And it could help us in certain situations, like in pregnancy or in thyroid ablation, where we may need to measure both thyroid stimulating immunoglobulin and TBII. Now, where I worked in UK, we always had TBII to measure as the first line, and I never had TSI to measure. My colleagues in the Imperial Center in Abu Dhabi, where they came from America, they said to me that they always use TSI in the United States. Now, TSH receptor antibody and the diagnosis of Graves' disease. As we all know, in order to have Graves' disease, you have to have a TSH receptor antibody to stimulate the receptor. Now, uptake scan, we all know it's the gold standard in the diagnosis. And the American Thyroid Association used to mention it's the first line to be used before any antibody. However, after the new generation of the TSH antibody, receptor antibody, second and third generation, the ATA guidelines changed and they mentioned TSH receptor antibody and uptake scan could be used in the diagnosis. Now, the new generations of the TSH receptor antibody, they cost much less compared to the uptake scan. Now, the uptake scan in the United States could reach up to $1,000 compared to the TSH receptor antibody, which costs $50 to $70. So it is much more cost effective. Now, in UK, what we used to do, if we see an abnormal thyroid function test, but I mean hyperthyroid, we will send for TBII. If it came positive, we will go for the diagnosis of Graves' disease. And if it became negative, then we will request an uptake scan. Now, remember, uptake scan needs organization and it's not going to happen in the same day, while you could get TSH receptor antibody in a day or two. Now, there are certain situations where the TSH receptor antibody is more helpful than uptake scan, like, for example, amiodarone-induced thyrotoxicosis. In order to differentiate between type 1 and 2, we could use a TSH receptor antibody. However, negativity of TSH receptor antibody in that situation doesn't mean that it is not type 1 amiodarone-induced thyrotoxicosis. Also, TSH receptor antibody is more helpful in pregnancy and breastfeeding as it is contraindicated to use uptake scan. Now, what about, so this is for the diagnosis of Graves' disease. What about the course, during the course of Graves' disease? What will happen? So a small study by Lorberg came with 131 patients, and they randomized them to a patient on antithyroid drugs, patient had surgery, and patient had radioactive iodine. And they followed the patient for 5 years with monitoring of the TSH receptor antibody. They measured the TSH receptor antibody every 3 months for the first 3 years, and then every 6 months afterward. Now, logically, they found a decline in the TSH receptor antibody when we used antithyroid drugs and surgery, and they found the reduction is almost 70 to 80% in around 18 months. While radioactive iodine increased the TSH receptor antibody for 1 year, and then a gradual decline happened. And remember the alpha subunit that we mentioned, as radioactive iodine will destroy the thyroid cells, there will be more alpha subunit outside, and that will lead to a response from the immune system by increasing the TSH receptor antibody. And that will take a year to start a gradual decline. Now, this is a bit busy slide, I'm sorry, but it's a very informative slide of which it collected all the studies with a reference range of the cutoff of the TSH receptor antibody. Now, if we see, they measured the TSH receptor antibody at the time of the diagnosis, and they used a cutoff of 12 to see the relapse in 2 years and 4 years. And then after 12 months, of antithyroid drug treatment, and they use a cutoff of 7.5. And then after 18 months, when we are trying to do cessation of the antithyroid drugs, and they use 1, 1.5, and then 3.85. And then 4 weeks after cessation of the antithyroid drug, and they use 1.5 and 10. Now, what parameters they use is sensitivity, specificity, positive predicted value, and negative predicted value. And you can see in 12 months, when we use the cutoff of 7.5, it's a fairly high specificity at 97%, and fairly high positive predicted value at 97%. And the same thing when we use the 3.5 at 18 months is a fairly high specificity and positive predicted value. Now, if we look into all the categories, we see negative predicted value, and all the negative predicted value is a fairly high numbers. And what does that mean in the TSH measurement? Means that even if the patient is below their cutoff, that doesn't mean that they will not have relapse. So they still could have relapse, but it could take longer time. Now, to translate this into a better way of saying it, we normally, when we see a patient with a grave disease, and we do not interpret the level of the TSH receptor antibody, we will say that the antithyroid drug could have a relapse rate between 50 to 60%. And we use antithyroid drug as the first choice. However, if we measure the TSH receptor antibody with a number, and that came more than 12, the antithyroid drug relapse rate jump into 60% at 2 years and 84% at 4 years. This is where other measures of treatment or on longer term of grave disease comes into help, like radioactive iodine. And they don't have moderate to severe graves of thermopathy, and they're not planning for family in the next 2 to 3 years, radioactive iodine would be a more sensible choice. And at the same time, after 12 months of antithyroid drug, if the TSH receptor antibody more than 7.5, and after 18 months, if the TSH receptor antibody is more than 3.85, the relapse rate really jump into more than 90%. And this is where definite management should come into consideration, whether we use, again, radioactive iodine or thyroidectomy, or sometimes we may even say to the patient, we'll leave you on long-term low-dose antithyroid medication if there is a contraindication for more definite management with the patient. Now, this is a slide from UK studies where they're showing that the cost of antithyroid medication, carbimazole here in different doses, propylthiouracil, compared to radioactive iodine and surgery across the years in the last 14 years has really jumped. So anti-thyroid medication almost jumped 3,000% compared to the radioactive iodine and surgery. So the choice of definite management from the beginning could be not only better to predict less relapse, but it is also cost effective on the long term. Now, what about TSH receptor antibody and pregnancy? Now, TSH receptor antibody can help us in differentiation of thyrotoxicosis in the pregnancy because of, for example, hyperemesis gravidarum, or if the patient has a genuine grave disease. Now, TSH receptor antibody as an IgG antibody can cross the placenta. And if it crossed the placenta, it could lead to fetal and neonatal thyrotoxicosis. Now, in a small study where they took 47 patients with positive TSH receptor antibody, they found that a cutoff of more than or equal 5 IU per liter in the second trimester predicted almost 100% sensitivity and 43% specificity in predicting neonatal hyperthyroidism. So this is why the American Thyroid Association recommended measuring the TSH receptor antibody in early pregnancy. And it is indicated for patients who have grave disease and they are taking currently antithyroid drugs, or patients who had a previous radioactive iodine or thyroidectomy in the past. Remember, patients, we remove their thyroid, but they still have the same immune system, which could generate TSH receptor antibody. Or if a patient delivered an infant before with hyperthyroidism. So the recommendation is to measure it early pregnancy, and then if it is positive, we repeat it in 18 to 22 weeks to assess the need for further monitoring in 30 to 34 weeks to see if there is an elevated TSH receptor antibody. Now, as we all are aware, that pregnancy is an immunosuppressive condition. So grave disease sometimes do reduce inactivity, and sometimes we may be able to stop antithyroid drugs. This could be helped as a decision if we see that the TSH receptor antibody is undetectable. We could go and withdraw the antithyroid drugs. Now, what about Graves' ophthalmopathy? Now, we all know that TSH receptor antibody lead to an increment in the production of hyaluronic acid, and it will make fibroblasts make more adipose tissue. Now, in a study, they found that the TSH receptor antibody level more than 8.8 IU per liter when they followed the patient for 5 to 8 months predicted 18 times increase in the risk of development of severe Graves' ophthalmopathy. And as you are all aware, Graves' ophthalmopathy, when it reaches to such a severe state, it has a devastating effect on long term to the patient. So a meta-analysis using a randomized controlled trial of 850 patients, they used treatment of steroids versus placebo versus no treatment given to the patient to see the progress of a Graves' ophthalmopathy. So for mild and moderate Graves' ophthalmopathy, they used a dose of prednisolone of 0.4 to 0.5 milligram per kilogram for 3 months, and they tapered it. And for low-risk patients, high-risk patient like smoking and high TSH receptor antibody, being a man, and if they have a mild Graves' ophthalmopathy, they used a small dose of 0.2 to 0.3 milligram per kilogram for 4 to 5 weeks. And they saw the risk that we mentioned above reduced significantly. Now, what about normal individuals? Do they have a TSH receptor antibody? As we all know, we would never measure TSH receptor antibody for people who doesn't have a normal thyroid function test. So a study done in Japan where they took ladies and they measured their TSH receptor antibody, and they followed them for a few months down the line. And you can see the individuals started from the cutoff limit, which is almost 1.8, and they were all positive. And you can see the different patient where some of them had really high peak to see the prediction would they develop grave disease or not. So their conclusion from this study is that almost more than 10% of patients who were euthyroid but has a positive TSH receptor antibody developed grave disease. And this was in a median of around 6 months. And what they also mentioned that a positive result of TSH receptor antibody itself does not mean the development of grave disease, because there are other factors that could be essential for the pathogenesis of a grave disease. And they mention a very important percentage that they think the overall prevalence of TSH receptor antibody positivity among fertile age women in Japan is almost 1%. So my conclusion is TSH receptor antibody assays are much better compared to before. The second and third generation assay are much more specific and sensitive compared to the previous assay. And we can use it because it's much cheaper compared to the gold standard uptake scan. It will help us in the diagnosis. It may help us in the deciding the management, the long-term management from the beginning, and the also when to stop anti-thyroid drugs and predict the relapse in the future. Now, also it's helpful in the predicting fetal or neonatal hyperthyroidism, as TSH receptor antibody does across the placenta. And we've seen that a very high TSH receptor antibody can predict severe graves of thermopathy and may require earlier treatment. And thank you very much.
Queries for clinicians. We are open for questions. Please send in all your questions. I will start asking you some of the questions we received. The first one is those Americans that you mentioned who do TSI, what are they missing in terms of information when they see Graves' disease patients straightforward if they only do TSI?
So for example, I'll give you a case which I had in Leeds before. I had an Asian lady who had a TBI of more than 100, and she came in with the Graves of thermopathy. And I started her such a high number. If we had a TSI for her, maybe we'll get a much lower number. And I started her directly on antithyroid medication. I thought, this is such a high number, she must directly go to definite management. And definitely we're going to go for surgery, as she had a sort of mild to moderate Graves of thermopathy. So only in 1 week, I started her on a 40 milligram of carbimazole. Only in 1 week, she went directly into hypothyroidism, which we never see normally, because even if we do block and replacement for a grave disease, we will wait at least for 4 to 6 weeks to repeat the thyroid function test, and then we will add levothyroxine. So in 1 week, she went into hypothyroidism, and we predicted this because she has a very high TBII. So she must have quite a big number for inhibitory immunoglobulin and stimulatory immunoglobulin. And once we added levothyroxine, we referred her directly to surgery. So in a level, if I only did TSI, then I might get a much lower level compared to the TBII that I get. Now, it is much more specific for Graves, though. So if we want to know whether the stimulation is there, yes, TSI is better, but it is a little bit more costly compared to the TBII. And as you know, the NHS system works by the least cost, hence we don't have it more frequently. And when I was chatting to some of my colleagues, even from Manchester, they were saying that they didn't used to get a number with their TBII because they use the first generation. You found this, we are in the 21st century and they still use the first generation from 1970.
Thank you. Unfortunately, TRAB takes a long time compared to TSI, which is done locally.
Yes.
And we have to send it to Europe for us in Bahrain. So we prefer TSI just because of the convenience and the
Yes.
speed of results here. Okay. Another question, Dr. Ahmed, is the benefit of selenium and statin in Graves' eye disease. Is it related to an effect on the antibodies?
So so I remember the study that we presented before with Ramsey. Now, the mechanism is unknown. We don't know why selenium affected, but the effect is only for 6 months. There is no benefit more than 6 months, and in such a low dose. So using selenium only for Graves is not helpful. It's only for ophthalmopathy and only on a fairly low dose and only for 6 months. How it's doing the effect, we don't know yet.
I see. Thank you. Now, the other question is, after 18 months, do you need undetectable levels for antibody to stop, or just mild elevation can make you?
So I mean, what I used to do in UK, we are guided by the thyroid stimulating hormone and the whole thyroid function test. So we don't usually measure it, but maybe because we still have some effect from the older assays. But remember, if you measure it, and it's just a cost of $50, for example, and you have a very high number, then you will know that you need to predict that there will be a relapse. And remember, we are not only talking about a relapse, because you can still have, in relapses, you can still have Graves' ophthalmopathy. And you all know that Graves' ophthalmopathy has such a negative impact on the patient quality of life. So we've seen so many patients on relapses, it will come with a Graves' ophthalmopathy, especially if they have a very high TSH receptor antibody. So should we use it for everybody? I don't think we should use it for everybody. Maybe we should use it for people who have a high TSH receptor antibody at the beginning, and we decided to go with antithyroid drugs. If the thyroid is small, if they responded very well to the antithyroid drugs, and they didn't need a treatment for a year or 18 months, I don't think we still should use it. And remember, the negative predictive value is still, even if we go with the cutoff, it still could show us that some people could return and have relapses on a longer period. So is it just doing it will give us a decision? No, but it will give us an idea about what should we do.
Thank you. Another question is, sometimes in practice we see typical Graves' disease, and yet the TRAB and TSI comes back negative. So is this common? Do you see this in practice?
I've seen it a few times, but the course of when we see it negative, we send for uptake scan. What we used to do in Leeds, we can't do it in Imperial that much in this era. But the uptake scan will give you the diagnosis. Remember, it's an autoimmune condition, so it will have up and down of the antibodies like every autoimmune condition. So just like type 1 diabetes, we could miss the antibody, but still it is type 1 diabetes. The course of the repeated measurement will let us know if this is a thyroiditis versus Graves' disease. We just have to be safe and play it safe. If there is uptake is available, I would do it, but I wouldn't just completely exclude Graves with negative antibodies, especially if there is some time. And there are other way of measuring Graves. If the patient has some Graves' ophthalmopathy, that's the diagnosis. I don't need the TSH receptor antibody.
That's right. And sometimes they give you a long history of thyroiditis, and you become suspicious. Is this really thyroiditis or just Graves' disease, and the antibodies are not measured?
Yes. Interestingly, I remember we had one of our colleagues in Leeds who had a COVID vaccine. And suddenly her T4, the normal value that we use is up to 22 in Leeds. Her T4 went to 77 just after the COVID vaccine. And we sent her for TSH receptor antibody. It came back positive. But then after a few days, we repeated the test. The thyroid function is coming down, came back positive, but quite a fairly low positivity. So we used 1.8, she came like 1.85. And when we did the uptake scan, it looks like a thyroiditis picture, not a Graves' disease picture. So we could still have some people who have some maybe a little bit positive test, but they are in thyroiditis, especially when we are, augmenting the immune system to provoke something like with COVID vaccine.
Yes. Even COVID disease itself, there were reports of increased.
Yes.
Thank you. Another question here. regarding if you have a patient who had, after 1.5 years, have very low levels of TRAB antibodies, and you felt comfortable to stop the last dose of the medication, oral medications. Is there a chance that the antibodies will come back again and then get a relapse, or the chances are very small?
Yeah, well, there is a chance. As this is why the negative predictive value is showing. It's fairly high in every way we measured it, because again, it's an autoimmune condition. Antibody could go up and down, and we could be not measuring it at that time. This is why the recommendation, because of the negative predictive value, is to keep measuring the thyroid function test 3 months for a certain period, and then after 6 months, and then on yearly basis. Even if the patient is euthyroid, we still monitor the thyroid function test because we know, because of the negative predictive value, it could relapse back again.
Okay, thank you. One of the conditions we see in practice is type 1 diabetes, and in some of the studies, they have a chance of thyrotoxicosis by almost 25 to 30%. Would you advise screening, if available, to see if they have the antibodies, although the TFTs are normal, to see if there's a...
I don't think there is any benefit. Remember, you've seen these patients that developed, only 10% developed the condition. And even if we predicted what we're going to do about it, unless they will start to have an abnormal thyroid function test. So I know a person have a TSH receptor antibody positive, and then am I going to take the thyroid off or do a radioactive iodine? It's a big risk, and there is no benefit of giving NTTD, and the patient is still normal thyroid. So still, it's not beneficial to do it from the beginning, but maybe it will make me feel more, strict about monitoring patients. You've seen the study from Japan. It's almost 1%, they were saying, of their females have positive TRAB, but maybe because they caught it in certain time where they developed that antibody. And you can see some of them really went up, and they returned back to normal. The 1% explanation is because we all have such a strong immune system. Any shed of this alpha subunit, you may get a surge of TSH receptor antibody, but then it may go away and not necessarily causing a problem.
Very interesting. Thank you. Another question about pregnancy. Would it matter if you do it the first or second or third trimester to predict the neonatal thyrotoxicosis?
Yeah, you've seen the ATA guidelines. They wanted early pregnancy and then 18 to 22 weeks and then 30 to 34 weeks. And this is not because they're going to treat the baby intrauterine. It's just because to warn all the teams that the baby, when come out, they have to start measuring their thyroid function test, and the endocrinology, pediatric endocrinology will be available so that they can, start treatment directly. So the measurement is in every trimester almost, because they want to see the prediction. If the measurement was positive at the beginning and then negative, then it's less warning for the baby to have thyrotoxicosis.
Interesting. Yeah. I just saw a case a month ago. She looked thyroiditis to me, and I did the antibody just to assure her it was negative. So she traveled for vacation, and she saw somebody in that country, and they said, let's do the antibody. And it was highly positive. And they told her, you have Graves' disease. She finished her vacation, and she came back to me. And when I saw her, she was hypothyroid in a matter of few weeks on a small dose of carbimazole. So I stopped it, and then I followed her, and she does have normal thyroid function. So
how long she was treated for?
It's only about 2 weeks, 10 days to 2 weeks only.
So probably they used an all the say, and that the all the say gave them a positive result, which is not true, because it can't be. If you have, whether you have a new generation of TBI or TSI, you're going to get, it's a stimulatory, so you're going to get a high thyroid function test. But if they use an all the say, that will confuse them, and they start the antithyroid medication. I mean, Graves' disease in 2 weeks will not be treated. You can't have a treatment in 2 weeks.
Yeah, it looked thyroiditis, but when they told her Graves, I was like surprised. And then we had the antibodies in our lab negative, so it's interesting.
Yeah.
Um, just waiting for more questions. While we're waiting for questions, is it ELISA, the newer test for the generation of
It's
TRAB?
something called luciferase measurement. It's a sort of ELISA, I think. But their numbers of sensitivity and specificity, 99%, such a high numbers
Mm.
compared to the old generations. And this is why the old ATA guideline says uptake scan first, while the British stuck to their guns, and they were right at the end. Not necessarily they were right in everything. They were right at the end when they said, no, TRAB first. If negative, go for uptake scan. Well, still in America, my colleague was saying to me, she sent for both. They will do DSI and uptake scan together. And I thought, why would you do both?
Mm.
Because their insurance system is different than the UK insurance system.
I see. Thank you. More questions are coming. Yeah. You said it's $50, but is this UK figure or Emirates or?
So $50. So the what I found, $50, $70, £48 in NHS. This is all TBII. That's the numbers I'm finding. The uptake scan ranging between $700 to $1,200, but mainly in America. I don't know how much it costs in Middle East.
Yeah,
It's slightly more expensive.
here it's almost $120 in Bahrain for TSI.
Uh, for
120.
TSI, 120.
Yeah.
Yeah, but what we have in Middle East is we don't have a readily available uptake scan, though. That's the other problem. So in Leeds, I used to be able to get an uptake scan maybe quicker than TSH receptor antibody, because our TSH receptor antibody had to go to Newcastle, and that could take 2 weeks.
Ah.
So we do send it, but because we have to predict it in 2 weeks, not necessarily doing uptake scan. So clinically, we become much better in predicting it from the history. Because if you just dig in the history, I know it's very difficult to differentiate between Graves and thyroiditis, but sometimes you can predict it, especially if the patient has some sort of viral illness, if there is a family history, if there is hypothyroid in the family, autoimmune condition, it may point you towards the story of a Graves' disease. And then in 2 weeks, we will have the antibody. So it's a different setting in every health system, and you have just to adapt and shape your clinical skills accordingly.
Surely, yes, thank you. One question about the interference with the antibodies. Does biotin or any other supplements or medication can interfere?
I'm not aware, but I always discuss it with the local friendly biochemist, because there are so many interference nowadays. I can't keep up. Today they were talking about paracetamol for Dexcom and Medtronic in our Mubadala meeting. So if you take paracetamol, it could intervene with Medtronic Guardian 4 measurement for blood sugar. And paracetamol is very readily available. So if we suspect it and we think that this should be a positive antibody, I normally pick the phone and speak with the biochemist to say, these are the medication the patient on. Make sure I ask them about everything they take over the counter and discuss it with them.
Okay, another question is about the free T4 versus total T4. When you see patients on anti-thyroid medication, which one you prefer? Is it free or?
Well, free is better, definitely. And we even in UK we were using free T4 in such a not very cost friendly system. Definitely free T4. I wouldn't use total.
Okay, and the T3 total maybe is better than free?
And the T3 total is better, but also free T3 is also more available nowadays, and still we could use it. Now, there is an old way of seeing where the ratio of T3 to T4 to diagnose Graves' disease, but this is away from the 70s and the 80s. Not many people are still using it anymore because of the advancement in the antibody measurement.
Okay. Another question is, how frequent do you see neonatal hyperthyroidism among Graves' cases with pregnancy? How common is that?
Well, I didn't used to do the antenatal endocrine clinic, but we had a very good system in UK. I don't do it here anymore. We had a very good health system in UK where we were following patients strictly, quite every 2 months, and repeating their thyroid function test. So we didn't see it much because maybe of the repeated measurement and the planning ahead.
I see. A question I think you touched upon it, which is the patients who, after 2 years, doing extremely well on the lowest dose, and thyroid function test is absolutely fantastic, and you're ready to stop, but the antibodies are still positive. So the question is, would you try to stop and see what happens, or continue small dose?
So again, back to the antibody, whether it's 18 months or is it the 12 months. So the 12 months, they use the cutoff of 7. The 18 months, they use a 3.85, let's say 4, for example, and see if the increment in the relapse rate is fairly high. So there is always the possibility that you can discuss with the patient, can I leave you on a longer term of low dose antithyroid drugs? And I found it always, sometimes you just discuss it with the patient to see what is their preference. I remember I used to do also a private clinic in Spire in UK, and I had a patient who was a sailor who came in with a diagnosis of Graves' disease. And he didn't have a very high TSH receptor antibody, and he doesn't have a big thyroid. There is no other features of a Graves' disease. And I said to him, look, there is a chance that you could have a remission on antithyroid drugs. Shall we just start it? And what he said to me, he said, no, we can't, because I have to come to you every 2 months. When I was explaining to him, he said, as a sailor, I have to go to the sea every 6 and 9 months, and then I'll return back. So we referred him to radioactive iodine. He didn't like that idea. He went and took his thyroid off with surgery. And that was his preference.
I see, that's interesting. One question is, actually, it's a practical question, is that when you have the seronegative TRAB in a full-blown case with very high TFTs, and you decided to go for the scan, as you mentioned, and there's no
Yes.
indication. Now, I know as a fact, when I send somebody for scan, it takes weeks. So,
Yes.
so would you rather treat and then stop and do the scan, or just wait and give beta blocker and do the scan?
So this is where what I am saying is very different in health systems. So in UK, what we used to do, I just grab the patient and I'll take them to the nuclear medicine department, and they will do the scan directly. So that's very different compared to the Middle East. Here, what we have, I can't reach to a scan unless I referred, for example, to Cleveland Hospital, which is very different. I think from the history, if you're convinced about the Graves, you start a treatment, fine. Remember, you can always start symptomatic treatment with the propranolol, and just look for the sign of Graves or thermopathy. You can always sometimes see something. And if you're worried that the antithyroid drugs will make a big effect, you can still repeat your thyroid function test every 1 to 2 weeks, so that you make sure that you're not going to have a big drop until you have the scan or the definite diagnosis.
Okay, that's very practical, but sometimes it takes a very long time. So we prefer to treat actually, and then we can stop it just days before the scan.
Yeah, and I always find it very helpful if I teach the patient about the sign and symptoms. Hyper, hypo, this is what will happen to you. You need to recognize and come to us with what you feel.
That's right, yeah. Now, there's a question about seronegative high TFTs. Would they require a smaller dose because they are seronegative
No, not necessarily. So we used a lot of, because of the heritage that we have in Yorkshire and Leeds from Sheffield, we use a lot of blocker replacement. So we start on a big dose of antithyroid medication, like, for example, 40 milligram, not dose adjustment, because this is the blocker replacement is much more cost effective. After 6 weeks, we repeat the thyroid function test. And if the thyroid function test is back to normal, we add levothyroxine, roughly around 100 micrograms, depending on the weight of the patient, 1.4 to 1.6 microgram per kilogram. And then we do the thyroid function test once, and if it is okay, we'll leave the patient for 6 months. And that's a much better cost-effective compared to every 2 months of antithyroid drugs. So either I will do this approach. If I can't do this approach, for example, because it's most of the time as a female, as you know, it's more in females and the childbearing age. So we wouldn't like to give a high dose of antithyroid drugs. So I would go for adjustment, but I would be led not by the TRAB. I would be led more by the how high is the T4 level and the T3 level. So if I feel I need to give more, I need to give more. Because remember, you leave a patient on a very high T4, T3, they could go into all types of failure. Every system can fail in these patients, and they may end up in ICU because I didn't give them enough antithyroid drugs.
That's right. Yeah. Thank you. One area of query is actually the pre-pregnancy. A young lady, newly married, extremely high TRAB. And you mentioned in the graph that if it's very high, the likelihood of relapse is very high. So maybe surgery, radioactive iodine. So if she tells you I'm planning for pregnancy in 6 months, would you still go for radioactive iodine, or you lean towards surgery, which is better outcome for her?
No, I mean, for what they said is, you know, you need to be free for quite some time, in years, not months. So you just need to explain it. If she's insisting to go, you could always refer to surgery. But then otherwise, with radioactive iodine, they can't do that. Having said this, there are lots of situations where I remember Prof. Bolat was saying to us, they were all patient to her, and they had radioactive iodine, and they would tell her, oh, I'm pregnant now. And we are talking about radioactive iodine in a day or two.
Oh my God.
Yes, exactly. Because, you know, in UK is a different sort of a culture. You could have this at any time, which is very challenging. But remember, we have to, you know, say it to the patient, document it very well, and we'll give them the choices.
I see. One last question, I think. If you see somebody who's planning pregnancy, would you start right away PTU first and then await for her pregnancy and the first trimester, or you try the carbimazole until she gets pregnant and move to PTU?
So I usually switch to PTU if they are very serious in getting the pregnancy and they had no problem in the pregnancy. Otherwise, if they're very stable on carbimazole, I may say to them, look, the minute you will find out that you're pregnant, you come directly to the hospital, we'll switch you to PTU. So it depends on how the patient is and how far from the hospital can they reach to us on time. If they can't, then I would prefer just to switch to PTU.
Okay. I was asking about the new cases, just new case, and you ask her and she tell you, I'm getting married and I want to get pregnant. So the initial choice still be, if she's serious, we'll go for PTU better.
Yes, exactly.
But the problem is that she might take a long time to get pregnant. We don't know.
Yes, exactly. That's true. The PTU is a very good medication. I mean, the advantage of carbimazole of PTU, it also blocks T4 to T3. So it's a stronger medication compared to carbimazole. So what does carbimazole do is it will interfere in the production of the thyroid hormone. So the production of T4, T3 will be less directly from the thyroid, but it will not block the conversion of T4 to T3. While PTU, on the top of what carbimazole does, it will block the conversion of T4 to T3. So it's a much more effective medication to achieve a quicker response. However, you can't use it for block and replacement because there's never been studied, and it will prevent, because remember, what we do in block and replacement, you will give T4, which is levothyroxine. So if you're giving a medication like PTU, you're preventing what you are giving to be converted to T3. So this is why it's not been used in block and replacement. This is why we use carbimazole and levothyroxine. While PTU, it always has to be an adjustment dose medication, depending on the thyroid function test.
Thank you. One question related to pregnancy. A lady who took radioactive iodine more than a year ago, and
Yes.
she's hypothyroid and thyroxine. And during pregnancy, do you still do the TRAB as you mentioned? And if
Yes.
yeah,
Yes.
even after
Now,
1 year.
the ATA they were vague about what's the time limit, so it's open.
Okay.
So 1 year is a fairly recent one,
Yeah.
compared to and we will have, according to the studies, the highest level of TSH receptor antibody, and it will start to taper after 1 year. So we're still on the limit of its being tapered.
Okay. Interesting question about the combination of use antithyroid drug with radiofrequency ablation or microwave ablation to the thyroid to improve or expedite the recovery or the improvement in thyroid function.
I've never used it before.
Okay.
I mean, radio frequency ablation. It's not much in UK. I haven't seen it much here. It's mainly used for the nodules, the active nodules.
That's right.
Patient who cannot have radioactive iodine. I remember I only referred one patient to London before because he couldn't have a radioactive iodine to have an ablation. It's mainly for one nodule if possible. It does have a rate of failure,
Yeah.
though, but combination I never used it before. But anti-thyroid medication are quite effective medication generally.
That's right. And as I said, for Graves, it doesn't work. You need a
Yeah.
toxic nodule to use for.
Yes.
Um,
Yes.
Dr. Ahmed, you were in the conference of Gulf Association, and we
Yes.
presented Bahraini data on
Yes.
arterial embolization for Graves' disease.
Yes.
And we had
Yes.
beautiful outcome. Those people,
Yes.
they were not candidate for surgery. They were refusing surgery. They're not candidate for radioactive iodine. And we did a simple day procedure. They go home,
Yes.
just arterial embolization. And we have excellent results, honestly. So
Yes.
it's
Yes.
coming. So it's a very interesting field, actually.
Yes. Yes. Definitely. Definitely.
Thank you so much. That was very insightful discussion.
Thank
I
you. Thank you.
appreciate the beautiful data and brilliant information you gave us today and this
Thank
very
you.
hard topic. Dr. Ahmed is known to take the challenge of taking the most difficult topics and presenting them in the
Thank
most
you very much.
excellent way and easy way for everyone to understand. So with that, I'd like to thank you and thank all the audience for being with us tonight. And we look forward to see you on future Arab Thyroid Association webinars. Thank you all and have a good night. Thank you, Dr. Ahmed.
Thank you very much. Thank you. Thank you. Have a good night. Thank you. Thank you. Bye-bye.